Like I couldn't possibly think of how I can extend compassion to somebody else when I myself am overwhelmed. Nor are there really great tools or structures available. Like there's no button to press to say, oh, you're burnt out, I'm going to push a button, someone's going to come and help you. It almost becomes this massive grassroots effort just to get someone who's really suffering support.
So we got Blair or Dr. Bigham on and Bob Baillie. How are you guys?
We can skip the titles and just go to Blair.
Yeah, you okay with that? Whatever you want.
I totally am. Yeah, good morning.
Do you want to introduce yourself, Blair? Even though everyone knows.
Yeah, sure. Some of you may remember me from my time as a medic at both York and Orange, hanging out with Bob and a whole bunch of friends on the treks. And then I went to the dark side and headed over to McMaster to do training in medicine. And now I work in the ER and the ICU. I'm not too far away from York in Scarborough, my hometown.
Correct me if I'm wrong. Are you still at Stanford? Because Bob is catching us up with that. You were doing a fellowship.
No, I did my ICU fellowship down there during the pandemic and enjoyed my time in California, but I'm happy to be back home. Less so on a day where there's a blizzard, but still happy to be back home.
Amazing. Well, thanks for doing this. We really appreciate it. And Bob, the lovely radio voice Bob, introduce yourself.
Yeah, Bob Baillie. I've been a paramedic for 22 years, i.e. I have clearly settled. Apart from that, I'm an advanced care paramedic. I've enjoyed my time teaching, and I'll be very happy to partake any information I can.
Thank you again. Because this is quite timely, and we really appreciate both of you, but Blair's writing a new book, right? On burnout.
Yeah, I've spent the last year sort of digging into the topic of burnout, which seems to be, I don't know if using the word ubiquitous is a little hyperbolic, but a lot of people are feeling like things are falling apart. And that trend seems to have been since before the pandemic, but certainly the pandemic, the loneliness, the change in routine, the isolation has certainly seemed to exacerbate whatever burnout we were feeling beforehand.
So what is burnout then? How would you define that?
That's a good question. Burnout does have an academic definition, but the issue with that academic definition is that people don't really stick to it. So there are sort of these three domains of burnout that people tend to talk about. And the most prominent feature would be exhaustion, just feeling absolutely exhausted without any energy left. And I think everybody feels exhausted from time to time. I'm feeling exhausted today because I had a really busy week. But just being exhausted doesn't mean I'm burnt out. Another component of burnout is kind of feeling like you don't make a difference at work. You don't have what's called self-actualization. And that self-actualization means that when you go to work, you feel like you have meaning, like you have a contribution. And I think in healthcare, specifically health, and maybe not healthcare, but maybe teaching as well, any human profession where you're there to give, in order to feel like you've done a good job, like you've made a difference or that you've helped someone, you need to have that appropriate time and space. So you can imagine that if a teacher had 40 students in his or her classroom instead of 20, they might feel like they weren't able to make a difference to each one of those students. And it's the same for paramedics. If you are totally overwhelmed, if you're doing more calls than you think you can in the day, if you're stuck in offload delay, well, there's, a cardiac arrest or a choking baby around the corner that you can't respond to, then you're not going to feel like you're doing your best work. And so that's a component of burnout. And then the third component is this deep sense of negativity or cynicism or pessimism that can come when maybe the organization, the system isn't serving things the way it ought to. And the problem with becoming cynical or pessimistic is that the root reasons for that are often not within your control. And if you can't control something, then it's really hard to stay positive about it. And so that's sort of the academic definition of burnout. You have to be exhausted, you have to be cynical, and you have to feel like you're not doing your job. to your fullest capability. Like you're not making a difference. But if you go through all of the literature, and there are thousands of studies on burnout, what you'll see is that they kind of cherry pick bits of that definition. And also, they have to set a threshold somewhere. Again, I might feel exhausted a couple times a month. Does that mean I'm burnt out? I might feel occasionally cynical, who doesn't, crack the odd joke that is sort of pessimistic. Does that make me burnt out? I think different studies have used different thresholds. And so that's why I think burnout is such a commonly used word, but maybe not so well understood.
So that's a perfect bridge, because how's that different from a bad day? Because you're kind of talking about that already. And with PTSD, like those are very distinct disorders.
Yeah. So PTSD is a clinical diagnosis. It's in the diagnostic manual. It is a mental illness that requires professional care. It can lead to serious health consequences, including death. It is a health disease. It is like having adenocarcinoma in your colon. It is like having an ejection fraction of 20% with heart failure and coronary artery disease. It is a diagnosis that requires specific care. People who have PTSD don't always look like they have PTSD, just like people who have bowel cancer don't always look like they have bowel cancer. And so being able to recognize it, being able to diagnose it can be tricky. It can look like having a bad day sometimes. Sometimes it might not even look like those people have a bad day. Bob, maybe you want to talk a little bit more about how having a bad day is similar sometimes, maybe on the outside, to a diagnosis of PTSD, but is fundamentally different.
Absolutely. First off, medics are, it's really the only group I can speak to, Dr. Bigham. Now, medics are amazing at hiding their PTSD. We are forever sort of chameleons changing day to day. I find that the only way, having been through very serious PTSD and receiving hundreds of hours of therapy hours as a result of my diagnosis, the only thing I can tell you is that I can recognize PTSD in my fellow medics the same way I can recognize a heart attack or a stroke walking into a patient's home. You can look across the room and say, that's a stroke. I don't know whether or not it's hemorrhagic or whether or not it's symbolic, but you give me 2 or 3 minutes, I'll sort it out. Or a heart attack, and I'll tell you whether or not it's STEMI or not. But having been through it, you get that feeling with your colleagues, particularly the ones you know, just by the way they're acting, just by the way they look, whether or not they're tired, whether or not they're sarcastic, whether or not just how they're holding themselves at the hospital or how they're acting on calls. It's just, essentially, it's a very intuitive type thing.
I'd love to hear both of your answers on this, and because I was reflecting on this, and it's just the culture of healthcare where everyone kind of maybe half jokingly says, oh, that person's burnt out, but no one really acts on it, and we recognize it, but it's just, are we really doing support to them if we just kind of say it and don't address it, don't offer them support and everything? And even just post-pandemic world, how much are we seeing this more than prior to 2020? And Blair, you have the unique perspective. You work with paramedics and now physicians, nurses, and every other allied health professional. Do you see a difference in the pre-hospital world in comparison to what's happening in the in-hospital world?
I don't think I see a huge difference. I think whether it's a bad day or burnout or PTSD, we'll call it a syndrome of stress. This work-related stress seems to be everywhere. It does seem to be getting worse. We have some data that it is, in fact, getting worse. The pandemic certainly exacerbated things. Whether that is going to kind of peak and come back down on some sort of a curve is yet to be known. Certainly, we thought that, that crumbling of the healthcare system in 2021, 2022 would not continue, but I can tell from recent shifts that there is no improvement in emergency department and 911 demand right now. And so we continue to struggle. So I think when we see burnout in a colleague, whether paramedic, nurse, respiratory therapist, a physician, it's become so common that we almost don't feel any which way about it. It's just, oh yeah, of course you're burnt out. We're all burnt out. Why would I try to intervene? And what could I possibly do to intervene? It's almost like we're burnt out about being burnt out. Like I couldn't possibly think of how I can extend compassion to somebody else when I myself am overwhelmed. Nor are there really great tools or structures available. Like there's no button to press to say, oh, you're burnt out, I'm going to push a button, someone's going to come and help you. It almost becomes this massive grassroots effort just to get someone who's really suffering support. And there's always examples, we talk about this like green to red spectrum where some days you feel butternut squash and some days you feel banana yellow. But I think we all, like Bob said, when you're in the red, many people can recognize that. When you need help, you simply need to be booked off, leave the ICU, leave the ER, leave the field, go home, and probably speak to somebody professional to help you work through that. But when people are hovering in that yellow-orange space, they're not well, but they're not so unwell we feel compelled to do something about it. We really are letting people down by just letting things linger. And, you can imagine that without structural change, and structural change, if it ever comes, will be slow to come, those people are likely to slip further and further until they end up ill.
And that's extremely problematic. And correct me if I'm wrong, because I was looking up stats. Do you think these numbers are underreported or about probably where they should be? Because it's 30 to 70% of healthcare providers will have some sort of burnout. And I think it's 50% of physicians have some sort of burnout.
So those surveys are absolute garbage because, first of all, they're all self-reported.
Yeah.
They're often organized by an employer. So good luck getting someone to self-report to the people who pay them that they're unwell. Third, we have survey burnout, where there's so many surveys out there now that people don't even want to fill them out. And so the people who are the most burnt out probably delete the email. And so it's certainly an underreported prevalence. But also the thresholds and definitions of burnout used in each of those surveys are so all over the place that in one systematic review specific to physicians, you had burnout rates of anywhere between 5 and 90%. The 5%, I can tell you, they used a very strict, high bar for what constitutes burnout. And the 90%, if anybody was exhausted one time in the last month, they were considered burnt out. I'm sorry, wanting to have a lay-in one day a month does not constitute being burnt out. So it's really hard to go off of the survey data to help us understand what's going on. But certainly, just being on the front lines, I think we all know that people are not doing well.
Likewise, in paramedicine, we are very good at going to strangers' homes and helping them out in their time of need. However, with our fellow medics in base or just in the hospital, when we see that they're hurting, people are less likely to go over and help them.
And that's interesting, Bob, because paramedics have the skill set to walk into someone's house, instantly develop a rapport, instantly build a therapeutic relationship. And what is it, about 20%, 25% of EMS calls are for mental health.
And yet, at least related to mental health.
Right. And then when they're sitting with you in the cab of the truck, somehow we clam up. We're not able to have that conversation with a peer the way we could with a patient.
Really, all I've done, Blair, is I realized through all of my traveling and all of my talks on PTSD, the reality is you're only really talking to about 1% of the population. I spend my time, watching my colleagues, the ones that I know, and if they require my assistance, then I offer my assistance. But paramedics in general they're a tough nut to crack. It takes a long time to convince a medic, even a friend, a true friend, to book off. It takes a lot of effort to get that done.
It's interesting. We're all in caring professions, and part of that is a personal identity around giving to others, right? Like we miss our lunch, we get an overtime call. We are always putting patients first. And there's a deliberate attempt almost, I think, subconsciously, to not only not acknowledge our own suffering, but to actually be ashamed of it, to actually put that so far in the back of our mind that we can't even acknowledge it because it threatens our identity of being able to help other people. And so I'm curious, Bob, what do you think helps people be able to back down from that ego and become more reflective and aware of their own circumstances, their own feelings?
Well, I mean, now you're into number one, do they have a proper therapist? That's key.
So this needs a professional.
Yes, absolutely. I mean, will they listen to you for one? I mean, so do you have a group of people at work that you listen to, that you trust, that you are then willing to engage a professional with? For me, my PTSD, I didn't recognize my PTSD for years. And I'm not an unintelligent individual. I just wasn't self-aware. And that's probably one of the hardest things I had to admit going through therapy. I mean, you're sentient, that's fine, but you're not self-aware. And that is one of the major keys that results in people having PTSD. So in order to start the ball rolling is, if you're brand new, and I constantly do this with new medics that I work with, I'm like, I ask them, do you have a therapist? They're like, do I need a therapist? I said, you do. I said, if you're in this job long enough, for whatever reason, you need a therapist. They're like, but I feel fine now. I'm like, fantastic. Let your therapist see you at baseline. If this is fine, maybe 2 years from now, maybe 6 months from now, maybe next week, you won't be fine. At which point they have a baseline at which to measure from.
So let's talk more. I think this is important, Ryan, because very few people I know are willing to even say, oh yeah, I'll go talk to a therapist. And the times that I talk to a therapist, I have been actually forced into it. So there was sadly in 2012, there was a helicopter that went down in Northern Ontario with Orange. And I was on shift later that night at a different base. And our crew was not allowed to fly until a traumatologist, a specialized psychologist, came in and, quote, cleared us to fly. And at first I was very offended by that. And then this woman shows up at the base. She says, I'm going to meet with you all as a group and then individually. And I was like, all right, whatever. I understand how this works. This is like a cop investigating another cop for murder. Like I kind of have an inside knowledge on how you're going to do this. And I was stunned that within minutes, she had all of us on the verge of tears, exposing some really deep fears that I didn't even know I was experiencing. And so getting people to see value in having a professional guide you through what your own mind is having trouble working through, I agree, Bob, is really important.
The other major baby step that medics are probably, well, we're terrible at, is debriefing. I mean, proper debriefing, not critical analysis, nothing like that, but actually learning how to debrief a call. And every single time we do a call and we don't debrief it, I don't care if it's a small, medium, or large call, and that all depends on who you are, what point of your life you're in. You know, let's just say you go out and do what you consider to be a small call, and you don't debrief it. Consider the fact that your brain just creates a small item and sticks it in the closet. And then the next call you go to, it's a medium call in your mind. And then you don't debrief it and your brain creates a medium-sized item and sticks it in the closet. Well, eventually that closet fills up, depending on, what type of closet you're dealing with. Some people have a walk-in closet, some people have a small hallway closet, that sort of thing. But eventually the closet fills up. And then, as is our habit, because, medics are creatures of habit, one day you do a call, you don't debrief it, you create an item out of it, and your brain sticks it in this closet, and a couple of items fall out. And those items falling out are the beginning of the end there. And so the items that fall out might result in a complaint. It might result in you being angry at your partner, your wife, the dog, the kids, a patient, management, whatever it might be. But all of a sudden, you're starting to react. Eventually, the closet becomes so overfull that it bursts at the seams and everything comes pouring out. And that's full-on PTSD in a picture. At which point now you're forced to see a counselor, and the counselor's job is then to pick up all these pieces and look at them and try and figure out what call they're associated with and how they're affecting you adversely. That's a lot of work. If we learned at the beginning, before entering this job, how to properly debrief, ideally, you would never have a closet. That's the only way. That's the only way to positively progress.
Bob, you had mentioned in the benefits of therapy and that in therapy you became self-aware. What does that look like for someone? What does the therapist and the client do? Is there a moment? Is it like a light bulb or is it more like a dimmer switch? Yeah.
Yeah. Again, it's very individual. And I think it's individual for everyone. And you sort of realize it at some point. They'll take you through when they say, oh, we're developing tools on how to deal with PTSD. So those tools are different for everyone. It's different for the therapist. It's different for whether you're doing CBT therapy or whether you're doing psychotherapy, whatever it might be, whatever works for you. And I do want to point out, I had to go through about 6 therapists before I found the right one. It takes a long time to find the right person to connect with. And that can be very frustrating. And you're trying to do this while you have PTSD and you're not thinking clearly. You need somebody like before you get into PTSD. And you're going to find that person. Yeah, you need a therapist.
A psychologist or a family doctor? Who are you talking to?
Well, preferably a therapist. All right. If you have a proper counselor, a proper therapist prior to experiencing all of this, I think you would be much better off. But, for me, it was my therapist. She was like, okay, so look, we're going to do the sort of this self-body check type thing. She goes, when you feel stress, where do you feel it? And for me, it was sort of, in and around the solar plexus. That's just where I felt it. And she'd be like, okay, hang on to that feeling. Tell me what it feels like. And then she would start to basically dig at it. And we would start talking about it until that feeling dissipated. And she'd be like, all right, so how did we do this? What did we talk about? What is it like? What are the common themes that made you feel the way you did? This physical feeling that you had, what did we talk about just to make that feeling dissipate? And then you realize, oh, these are the things that bother me on calls. So, you might go do a pediatric arrest and people go, oh my God, that's a critical call. That's a huge call and this sort of thing. Pediatric arrest, it's just another call. It's just another call. They're not complicated. Maybe people find the drug math complicated, but for me, it was listening to the parents wail in the next room or listening to the father, smashing the side of the ambulance, trying to get in to see his child. I don't blame them for wanting to be with their child, but I found that very difficult to deal with as a paramedic whilst you're trying to do your job. And this is these actions that stayed with me versus the actual call. CPR, CP, intubations, IOs are IOs, drugs are drugs. Run the protocol. Look at the rhythm. Shock, don't shock. Move to the hospital quickly. This is the call. But the rest of it, no one prepares you for that. You're not at college and you don't have wailing parents on the outside trying to attack you, trying to get to their child. And that's not part of the scenario. Nothing can prepare you for that.
And that's a perfect point to bring up is like, where's the gaps? Because that was extremely insightful. And correct me if I'm wrong, Bob, would you have gotten that deep into thinking about all this without therapy?
Oh, absolutely not. Absolutely not. But one of the hardest points about therapy, I've been on the job for 22 years now. I think the hardest thing that I've ever had to admit to myself was I am not self-aware. When I found the right therapist, she said, what are your expectations? I said, number 1, I want to become self-aware. Number 2, I want to become a better human. And she goes, those are extremely lofty goals. And I'm like, everything else will self-resolve if we can work on those 2 things. And she's, okay, let's get to work. And hundreds of hours later, there we are.
That's key. And I'm just thinking from all our curriculum, because Blair, you can correct us if we're wrong. Like there are some strategies to treat burnout, and kind of mitigate its effects. But if we think about our schooling, we get taught this is PTSD, this is the clinical manifestations, this is burnout. But is there a huge gap in how to actually teach healthcare providers to become resilient and how to be self-aware and treat it?
Yeah. Okay, how much time do we have? So first of all, there's a lot of low-hanging fruit that's been somewhat studied. And the low-hanging fruit doesn't really seem to make a big difference. Things that do seem to make a big difference are implementable. So we'll start with small stuff here, are simply giving people choice. So if you give people a little bit of control, it goes a very long way. So this means scheduling flexibility. This means the ability to work where they want, when they want, obviously within operational bounds, but it means being as accommodating as you can over stuff that really shouldn't be that stressful, right? If you need a doctor's appointment, if you need to pick up your kid early, if you need to be at a family gathering, you shouldn't be super stressed just about having a life. And so I think one relatively easy thing that employers can do is make it really easy to have a life outside of work. So being able to do shift changes on your own through the computer system, being able to have flexibility in your leave time, being able to have holiday when your family is available for holiday. All of these things are relatively easy to implement and are shown to improve people's wellness, enjoyment of the job, commitment to the employer, and to bring about what we call a positive valence or feelings of wellness, as opposed to a negative valence or feelings of negativity and burnout. Other things that you can do that are often talked about, but maybe not the most evidence-based, are having structured debriefing programs. The pitfall here is that debriefing is a skill and it's very hard to scale. It's hard to just tell someone, oh, go debrief Bob, when that person doesn't have the proper training to debrief Bob. You also need to have the proper setting to debrief Bob, and standing in the garage at a hospital is probably not the right setting to debrief Bob. And then you have to have the appropriate follow-up in debriefing Bob, which in a lot of the sort of peer support team models that I've seen around Canada is lacking. It's sort of a one-touch. There's no real relationship. There's no longitudinal check-in. And the people doing that work, well, usually well-respected and well-intentioned, may not have sort of the psychology training required to be the most effective at it. So I think when we look at some of these sort of things that employers are or could be doing now, there's definitely room for improvement to help move the needle. There's a lot of low-hanging fruit that doesn't work. I think it's done more performatively. It meets a tick box. Council or a CEO or a mayor says, okay, what are you doing about PTSD? And you say, oh, look at these 4 things where we have chocolate Fridays where people get a free chocolate bar, and we have pizza parties after a hot call. None of these work. In fact, they can actually have a negative effect on burnout. In some cases, they can increase cynicism. When something horrible happens and you offer a pizza party, some people actually take that as an offense. And so I think good intentions can lead to bad outcomes. And if you feel like you're scratching the surface, that's probably all you're doing. What we're talking about are deeply rooted problems in the workplace, in the structural way that healthcare is delivered. And those solutions require top-down leadership that is brave and in some parts expensive or painful to structurally organize. There's a bit of a blessing in that there's only one stretcher in your truck. And so outside of an MCI, you're generally only caring for one patient at a time. You can imagine nurses in the ER who should have a ratio of, 2 to 1, 3 to 1, often being faced with 8 to 1, 9 to 1 ratios. I don't know. If you imagine having 9 patients in the back of your ambulance, you would go home saying, oh my God, I didn't get any of my vitals done. I didn't get any of my charts done. I wasn't able to provide emotional support to the people with anxiety. I wasn't able to even start an IV on someone who could have benefited from fluids. You would just feel like you didn't get to anything, that you didn't help anyone. And so I think in some ways, paramedics are in a way protected by the fact that their workload is somewhat gated in that you can kind of only do one call at a time. Now, even with that, the system has figured out how to jack up the pressure.